Hi, I'm Ann Greiner, President and CEO of the Primary Care Collaborative. And for those of you who may not know the Primary Care Collaborative or the PCC, we are a membership organization, 70 organizations strong, that is very diverse. We bring together primary care specialty organizations, behavioral health specialty organizations, consumer organizations, purchasers, health plans, pharmaceutical companies, tech firms. And what all of these organizations share in common is a commitment to strengthening the foundation of our healthcare system, primary care, so that we can get to a healthier nation. And we've got a lot of work to do on that front. Before we get into today's program, I did want to invite you all to attend PCC's summit on November 16th in Washington, D.C. Its title, Keeping People Primary, Building Trust and Better Health. And we'll put a link in the chat for you to register. We'd love to see you there. Our topic today is actually focused on this issue of trust and better health, examining whether or not we have a payment system that supports primary care physicians and other primary care clinicians to promote the kind of care that supports relationships, builds trust, and leads to better health. So we're going to examine something that has been long-standing in medicine, a pay gap between male and female physicians that exists across all specialties, and we're going to look at it in primary care. One of our panelists, who you will soon meet, Dr. Ashani Ganguly, has examined this pay gap in a paper that she published with others in the New England Journal of Medicine. Dr. Ganguly and other experts who you will soon meet will unpack the potential reasons for this pay gap between male and female primary care physicians. What are the implications for patient outcomes and its effect on the workforce? We'll also consider how Medicare payment, which really informs and actually almost dictates payment for all payers, it has this outside influence on payment, might be modified to address the issues that the paper raises. And this is obviously critical because we don't intend to, nor do we want to, shortchange patients, particularly those that have high needs, with a payment system that does that. Nor do we want to undervalue the foundation of our healthcare system, primary care clinicians or female primary care physicians. So let me first introduce Dr. Ganguly. She will present the results of her paper in the New England Journal of Medicine. Then we'll welcome 3 other experts, wonderful panelists with different perspectives, and then we'll leave the last 10 minutes for your questions. Dr. Ganguly is an assistant professor of medicine, health services researcher, and yes, she still practices as a primary care physician at the Harvard Medical School and Brigham and Women's Hospital. Her research focuses on primary care payment and delivery and the use and consequences of low-value care and gender equity. She's a member of the National Academies of Science, Engineering, and Medicine Standing Committee on Primary Care and a former journalist. Let me turn the baton over to you, Ashani.
Thank you very much. I'll leave the slides. All right, good afternoon, everyone. Thank you so much for having me, and thank you for the kind introduction, Anne. So, female clinicians are a growing share of the healthcare workforce, including and predominantly in primary care. And compared to male counterparts, female physicians have been found in numerous studies to do better on a number of outcomes, including among primary care doctors, increased use of breast cancer screening, avoidance of certain low-value tests, better diabetes outcomes, and in our colleagues in surgery and hospital medicine, improved post-operative outcomes among surgical patients and lower rates of readmissions and mortality among hospitalized patients. And yet, much like other industries that we know, there's a persistent gender wage gap in medicine. Now, this has been shown over decades. The wage gap is often estimated at anywhere from 8 to 29% in numerous studies. It's worse for those from underrepresented groups. And in this study that I worked on with Dr. Aurora and other panelists you'll meet shortly, we found that female physicians earned an estimated $2 million less over a simulated career. Now, in primary care, the numbers are a bit smaller, which is another issue. But what I point out here is that the gap is still $1 million over an entire career. What explains this gap? Our study and others have found that when you take into account factors like age, specialty, academic rank, NIH funding, leadership status among those in certain positions, the gap attenuates. So it helps to explain the gap. These factors in turn are likely driven in part by gender bias, and gender bias likely explains some of the rest of the gap that we have not yet been able to explain. But what about the role of hours worked? Now, this is a really interesting area because historically, researchers have often assumed or concluded that part of the reason that women in primary care and more broadly earn less is because they work fewer hours. And it turns out that this is really based on survey research, so self-reported data, and assumptions from those data about physician salaries as well as time worked. Have not been studies looking at clinical revenue, for example, or tying that to actual measures of time worked. And so these conclusions were really ripe for further exploration. So in this study I'll tell you more about that Anne alluded to, we used a national sample of all payer claims, so that includes Medicare and commercial and Medicaid and other payers, as well as electronic health record data that were linked. And these data contained, importantly, audit log or timestamp information, which essentially tracks what doctors are doing in the electronic health record to be able to estimate time spent on something like conducting a visit, so the actual time from the beginning to the end of a visit with a patient. We looked at these data for 24 million primary care visits across the country, and we specifically examined the relationship between work hours and compensation by physician gender. So what did we find? These analyses, important to point out, were conducted using practice fixed effects. In other words, we were comparing male and female physicians within the same practices for a more apples to apples comparison. So in these comparisons, about a third of the doctors we looked at were female. The female PCPs were younger on average, more likely to be in family practice. Female PCPs saw patients who were also younger on average, more often female. The female PCPs panels were about 70% women versus the male PCPs panels, which were about 50% women. And the female PCPs saw patients who are very slightly healthier based on chronic condition counts, 1.1 versus 1. Importantly, male and female physicians had about the same number of clinic sessions per week. When we looked at differences across the year that we were studying, we found that women had 11% less visit revenue, which was fully explained by conducting 11% fewer visits over just a few percentages, 3% fewer days. So large difference in visits, large difference in revenue, which is explained by the visits, over just really a difference of 5 days over the year. Yet, female PCPs spent more time per visit aggregated across the year than male PCPs. They spent 2.6% more time, which amounted to 1,200 more minutes or 20 more hours across that year, despite less revenue, which was due to doing fewer visits. We then drilled down to the visit level. Now, the physician level analysis I just mentioned was a controlling for physician factors such as age, specialty, and clinic sessions worked. In this analysis, where we drilled down even further to the visit level, we controlled for physician factors. We also controlled for visit and patient characteristics. For example, the patient's age, sex, race, marital status, their medical complexity. We controlled for visit characteristics, such as whether at a given visit, the patient was new to the physician, or whether the visit was for a low acuity condition. So after accounting for all of that, what we found was that male and female physicians earned the same amount, no difference in earnings per visit. They documented, but however, female doctors documented more diagnoses and in turn likely spoke about more diagnoses in the visits, placed more orders during the visits, and once again, spent more time. So a female doctor spent 2.4 minutes additional to male doctors per visit, or 16% more time. When you do the math, it turns out that per hour, female PCPs earned 87 cents to the dollar for what male PCPs earned per visit. These patterns persisted within a number of strata that we looked at. We looked at subgroup analyses by physician types, by visit types, and by patient types. And I'll give you one example here. So for patients with multimorbidity, in other words, those who had 2 or more chronic conditions, we saw the same pattern where female PCPs earned the same amount per visit. However, they diagnosed or documented more diagnoses, placed more orders, and spent, in this case, 2.7 more minutes on average with each patient. We looked at differences by gender of the patient and the physician, and we find that it's really driven by the physician effect. So what you see here on the left-hand side, the 2 bars show the amount of time that male PCPs spent with their male and female patients respectively. On the right-hand side, you see this time spent that female PCPs spent with their male and female patients respectively. And there's a slight but not significant difference in that female patients spend slightly more time with both doctors, but there's a large significant difference in the time spent between female PCPs and male PCPs. I'll also note here that female PCPs were more likely to leave money on the table in billing. In other words, they missed more opportunities to bill a higher level code for a patient visit, let's say at 99215, level 5 code versus 4 code, on the basis of spending time. So in other words, they spent enough time to bill, but they billed a level below. So what are female physicians doing with this time? So we know from prior evidence that female docs are spending more time on counseling and shared decision making. This is one study looking at and shows that female PCPs are spending more time on counseling, on sensitive topics, on health habits, and for example, female specific screening. Female PCPs are also spending more time on EHR work. Now, this is a study that came out of Duke and looks at doctors across the board and shows that female doctors spend an additional up to 1 hour in the system per day on the EHR, and that includes time on unscheduled days, time outside of scheduled hours, time outside of the usual work hours, and total time over the day. Now, they're spending more time, but it's not from lack of efficiency. This is important to recognize. So this is another study that uses data from UCSF and again finds that after controlling for any observable differences between male and female doctors and physician specialty, that women are once again spending more time in the EHR on various aspects of that work. Women are also using more of the tools that we get from the EHR, from Epic, to be more efficient. So for example, using documentation shortcuts that you see on the right-hand side here. And women are more likely to respond to patient calls within 24 hours, or they have a larger percentage of calls that are responded to in that time. Instead, it could be that female physicians may have more messages to respond to. Now, this is a study that came out of my own institution. I believe I'm part of the data set that was analyzed for this study. And so what Dr. Rittenberg and colleagues found here is that comparing men and women PCPs within the same institution and same clinics, women received 10 more staff messages per month and 53 more patient messages per month in the electronic health record. And this is after controlling again for factors that would otherwise might explain these differences. So in short, we're finding on average that female physicians are spending more time on face-to-face visits, as well as on non-billable services such as counseling and on non-face-to-face care. So these practice patterns are importantly desired by patients. Patients really value that time in visits. They value getting responses from patients, from their doctors off hours. And there's some evidence that this longer time spent is linked to better outcomes. So there's a study looking at the association between visit length and, for example, guideline concordant care for heart failure. Others showing longer visit length associated with better patient outcomes, or patient satisfaction rather. And we've done a study finding an association between longer visit length and lower likelihood of ordering low value antibiotics. And yet these patterns of care, this use of care, the longer face-to-face visit time, the non-billable services, and the non-face-to-face care are systematically undervalued by Medicare's fee schedule and other productivity-based payment models, which are still predominant in primary care practices across the country. This boils down to the idea that all PCPs really want to spend more time with their patients and to have that time and that space to talk and address all of the concerns in primary care that we don't have enough time in a year to discuss. And it seems that female PCPs are taking that extra time, but at personal and professional cost. So what are the consequences, I should say, of a payment system that undervalues time with patients? For clinicians, it's the wage gap that we talked about. It's also burnout. So for female physicians, it's that disconnect between the time they're spending and the wages they're getting, and the differences can really add up over time, especially when you think about underlying disparities in domestic responsibilities faced by women. Now, it's important to mention that the reasons that women have these different patterns is somewhat individual. It can be inherent or socialized traits that explain them, as well as interpersonal differences. For example, patients have higher expectations of women. But regardless, the impact of these differences can really have a major impact on burnout. And then importantly for patients, this likely translates to less effective and compassionate care, and specifically through incentives for doctors to spend less time with patients and patients not getting those benefits, and then also the downstream effects of attrition in the physician primary care workforce. So what can we do? There's a number of solutions, some of which are really focused at the health system or practice level. For example, streamlining asynchronous work, incorporating this work into clinician workflows, and using tools like patient education to set expectations, shared inboxes using team-based care, and even the use of artificial intelligence. And then there's the aspect of changing how we pay clinicians, which is going to be the topic of our discussion today. And I'm looking forward to hearing from the panelists on that one. One thing I'll mention to build on that conversation is a study that my colleagues and I did after I followed the New England Journal study. This was published in the Annals of Internal Medicine, where we did a modeling exercise to understand how the gender wage gap for PCPs might change if different compensation models were applied. So in this study, we used data from 2016 through 19, a national clinical registry, and we looked at about a little bit less than 2,000 primary care physicians across the country. And we matched male and female PCPs once again on factors like specialty, years since medical school graduation, their practice site, and their sessions worked. In this microsimulation model, we assumed that the revenue coming into each practice was based on what the group collectively brought in through fee-for-service revenue, and we adjusted how that revenue was dispersed, and that was what we used to look at differences between gender. So in the productivity-based model, the sort of status quo, we found that wage gap was there, as we had seen in many other studies. That wage gap did not change when we looked at capitation. When we did risk-adjusted capitation for age and diagnosis score, the gap actually got worse. And I'll just point out briefly that some of that may be related to potential disparities in the way that risk adjustment is done, in that traditional scores like HCC and the Charlson comorbidity score tend to favor diagnoses more commonly found in males or men, so male patients. When we looked at capitation adjusted for age and sex, the difference or the wage gap diminished and became non-significant. It's not to say that adjusting for age and sex when deciding on compensation is a solution, because as I've mentioned earlier, a lot of the differences are really driven by differences in physician sex as opposed to patient sex, but it may be one way forward. So putting this all together, I show that the gender wage gap persists in part because of current payment models that systematically undervalue traditionally female practice patterns. And this has consequences for patients as well as for all physicians, regardless of gender. Solutions might include streamlining asynchronous work, but also trialing new payment models that address some of the and support some of the non-face-to-face care and other aspects of care, and generally reward time well spent. But we really need to proceed with caution, given what I've shared, that it's not a guarantee that these new models will address the wage gap and in turn keep our physician workforce healthy and strong. So I want to thank my collaborators in this work, and I'm looking forward to the discussion.
Well, thank you so much, Ashani. That was fabulous, and there's certainly a lot to talk about. Let me quickly move to introduce our panelists who are going to first react to your presentation, and then we'll have a conversation. And again, be thinking about your questions and put them into the chat so that we can lift them up. First, I'd like to welcome Mai Pham. She's president and CEO of the Institute for Exceptional Care. And that nonprofit is dedicated to transforming healthcare for people with intellectual and developmental disabilities. She was formerly Vice President at Anthem, and prior to that, Chief Innovation Officer at the Center for Medicare and Medicaid Innovation. Welcome, Dr. Pham. Next, I'd like to introduce Toby Oliver. Toby is the Senior Policy Advisor at AARP in the Public Policy Institute. She focuses there on healthcare, particularly Medicaid, protecting and expanding access to benefits and coverage in the Medicaid program, and quality and affordability. Prior to AARP, she was in the Medicare Medicaid Coordination Office at the Centers for Medicare and Medicaid Services at HHS. Welcome. Very nice to have you, Toby. And then finally, last but not least, Dr. Vinnie Arora. Dr. Arora is the Herbert Abelson Professor of Medicine and Dean for Medical Education at the University of Chicago Medicine Pritzker School of Medicine. She oversees undergraduate medical education, graduate medical education, continuing medical education, and provides key leadership for the simulation-based training programs at the University of Chicago. She's prolific in her research, has done a lot on this topic of pay equity, and has been cited over 10,000 times for her peer-reviewed work. Wow, we've got an incredible panel, and I think we can take down the panelist slide so we can really see everyone. And my first question is for our reactor panel to reflect on Ashani's presentation, and also think about, given how outsized the role of Medicare payment is, what would you recommend as one change to make to try to address the issues that Dr. Ganguly has raised? And why don't we start with Vinnie?
Thank you so much for having me, Anne. I'm pleased to be here, and want to, kudos to Ashani, Dr. Ganguly, for a riveting presentation, and I want to just acknowledge her compelling voice in bringing data to these questions. So, a lot of people talk about gender equity, but it's very different to have the receipts. So Ashani brings the receipts. As Dean for Medical Education, I do want to, one thing that picked up on with the presentation is women are doing this at, quote, personal and professional cost. That's not sustainable in our workforce for anyone. And we already have a shortage of primary care physicians. You can log on to social media and people cannot find doctors. When I am meeting with trustees, the number one question they ask me is, how can I find a primary care physician or pediatrician? This is, and even as using my own agency as a physician and a leader, the next available for a pediatrician is, down the line, same with primary care. So this is real. It's getting very real. There is a crisis. And unfortunately, it takes 7 to 10 years to produce a primary care physician or a physician, period. So the shortages that we see today reflect workforce choices made a decade ago. And so without turning the tide right now, we are going to face a tsunami of aging population, increased disability, from a variety of sources. We already have worse chronic health outcomes than other nations, and we won't have the workforce to meet their need. And of course, there's a shortage and a maldistribution. But when you find a good primary care physician, so there's two things that happen. One is you complain about getting a primary care physician. The second is when you find one, you're like, they don't have time for me. So here we are, Ashani presenting this great data. Women are doing a better job. They're doing what they want, what people want, but we don't value it. And so can we be brave in our society and actually value what the people need? And, I will defer to my colleagues on the mechanics of payment policy. what I will say is what I know from my trade, which is medical education. I have amazing students who are $200,000 in debt, who, when faced with the disparity in pay between what a specialist makes and what a primary care physician makes, and also looking at that practice hassle, and a lot of them are women, they are choosing procedural fields. This is something that I think is happening in every medical school, and it's something that we really need to think about. We should have the best and brightest going into primary care. And so my pay policy suggestion would be to narrow, not only reduce debt on entry so that people can follow their career without worrying about, sacrificing their personal and professional cost and well-being, but also narrow the gap between specialty and primary care so that it's not the widest in the world, and that we're not, we are producing doctors that we know in the distribution the nation needs. So that's one medical education policy that I would put forward, and there could be others like increasing GME spots in primary care. Those bills are also on the Hill as well, and I'm a big advocate for those as well. So thank you.
Thanks so much, Vinny. Toby.
Hi, good afternoon. Thanks for having me on this important discussion and some really interesting, though unsettling findings. Speaking on behalf of AARP, primary care is something that AARP has long been concerned about and the state of primary care in our country. And we've been interested in ways to better support primary care through payment models, addressing staffing shortages, and ensuring that practices in particular that treat the most vulnerable individuals and populations are sustainable and able to continue providing the best care. We know primary care providers are really especially good at managing care for those with chronic conditions. And we know that people tend to have more chronic conditions as they age and report higher rates of disability and poor health. And we also know the American population is aging. These facts increasingly put more pressure on primary care on top of burnout and primary care shortages that are growing concerns. And ways to better support primary care staff are essential. I think the research that we're hearing about today highlights all of this. More time with patients can help with many primary care challenges and improve health outcomes, but our system often doesn't reward that time, at least financially. One often overlooked but critical support for primary care teams in their mission to help patients that I wanted to know today is caregivers, and related to Medicare payment policy. Caregivers can really help support the primary care objectives for patients in so many ways. And recently, the Centers for Medicare and Medicaid, or CMS, proposed some updates for paying for the way they pay for services in Medicare that we think can really help support primary care practices and providers in providing high quality care. And these include new codes for providers to be paid for caregiver training in Medicare, which is a really monumental step in recognizing the essential role that caregivers play in healthcare and supporting them in that role, and helping support primary care providers support them in that role. The proposals also included support for telehealth and behavioral health professionals, both of which play important roles also in supporting primary care teams and providing accessible and effective care to patients. We hope CMS finalizes the proposals and takes additional steps along these lines in the future. Medicare is such an important player in the healthcare landscape. Not only do decisions and changes made in the program impact its 65 million enrollees, but they also have a ripple effect beyond the program.
Thank you, Toby. Great thoughts. Mai.
And so I think we don't need to spend a lot of time talking about the known ills of the current payment system. I think the question really is, how do we shift from a reactive mode to something that at least makes an attempt to get ahead of the trends that we're so familiar with now. And by that, I mean several things. Totally agree with Vineet that, what we're living with today are the product of career decisions made a decade ago. It is also the case that we have burned through a lot of goodwill. I would venture to guess there is zero trust between primary care clinicians right now and payment experts or policymakers. I think that we need to recognize that, and recognize that once you've earned trust, it actually takes much longer to rebuild it, and it takes more drastic action to rebuild it than what you would have had to do had you been meeting expectations all along. So because we have squandered 20 years talking about patient-centered medical homes and ways to support primary care at the margins, and a little bit of pay performance, a little bit of care management fees here, and some more pilots and some more pilots, I think primary care clinicians are done. They're just done with the incremental stuff. And until policymakers realize that they will not pay attention anymore to incremental things, I think they will be continually disappointed, for example, at the rates of uptake of new primary care payment pilots across the industry. People are tired. They don't believe that these are permanent solutions anymore. They have enough to worry about. They're simply not going to invest in an engagement that they do not believe will be sustainable and meaningful. So I think that's message one for policymakers, Anne, is that you have squandered trust, and now you have a much harder job to regain it than you might have had a decade ago. And then I would just also point out that there are macro trends that we haven't voiced explicitly. We all know about them, but that we're swimming against as well, right? So it's not just the absence of a more modernized, rational way to pay clinicians, especially through Medicare, because that becomes kind of the template for so many provider contracts across the country and in the private sector. But it is also the case that when primary care clinicians and practices are tired and they feel out of options, they look for actors who will take burdens off of them, whether they be administrative burdens or capital burdens. And hence you see the tremendous consolidation, the vertical consolidation with health systems, and the wild purchases by private equity. None of those actors are interested in supporting the kind of primary care that Ashani profiled as being what women PCPs in particular are good at delivering. Private equity investors do not care about those outcomes. And the more time that we give them to become entrenched in the industry and in the sector, the harder it will be to rebuild and reinvest in that capacity. So that's the ticking time bomb that we're working against. I'm worried we're already past critical mass there, but it's not just the fee schedule. It's the fee schedule and much more. And so I think what we're really talking about is a very aggressive policy agenda that needs to be activated at multiple levels. It is not just on public policymakers. It is also on every health system and large medical group that is paying physicians or paying other PCPs to think about their compensation structure and think about where they want their organization to be in 10, 15 years, when they can no longer attract any PCPs, or when they can only attract the kind of PCPs who will deliver transactional care and not relationship-based care. When that will then result in them, frankly, failing in Medicare Advantage, which is where they all want to go and make money. But you will fail in Medicare Advantage if you are practicing only transactional care, because smart, engaged elderly patients with multiple chronic conditions know when they are getting transactional care versus when they are getting the support they actually need. And it's not just, warm and fuzzy stuff like the ministering and the healing that clinicians do. It's the smart, integrative thinking you need to have as a PCP to solve problems and get the right diagnoses and make the smart referrals. So they, from a business perspective, I think the problem we're fighting against is not just profit, but it's short-termism, because you'd make a much healthier profit in the long term if you were worrying about that now, and thinking about you're getting all this great prepaid revenue from Medicare for MA or from your private health plans. Do something with it, please. Don't just rely on your typical RP score sheet, because you're just making your business strategy 5 years from now that much harder.
Ma, you have laid down the gauntlet clearly, and I think you've really underscored that we can't pilot our way out of this crisis, that incremental change.
Right, because which one of us would make a career decision based on a 5-year pilot? Raise your hands.
So I think what you're suggesting is in order to avert what we're already seeing happening across the country, I have sent out clips over the last week of broadcast stories about the primary care crisis in the VA, in the commercial sector, in communities across the country. So it's not a distant notion. It's upon us right now. And we better move fast, because if that foundation, which already has cracks in it, collapses, it's going to be awful. It's going to be awful for the patients and for primary care, but guess what? It's going to be awful for the specialists, because their offices will be flooded with people that they really should not be seeing, and they will not be able to get to the folks that really need their care. So we at our peril if we don't move quickly. You did, so let's just talk a little bit about, and I really want to put this back to you, Mai. As the payer that has the ability to shift the market most dramatically, if you were at the head of CMS, what would you be promoting, as the first move? And then I really do want to open it up and also ask about others in the healthcare system. What should be commercial plans doing? What should health systems be doing? What should medical groups be doing? Because they have, the ability to set pay. Nothing's stopping them from changing the way they pay primary care and how they pay primary care in order to get the kind of primary care that Toby was talking about that really will make a difference in patients' health. So first to you, Mai, and then want to open it up for everybody else.
Yeah, and I guess if I could be the CMS whisperer, I would say it's important to remember several things. One, that CMS is not just a payer, they are also a regulator. And so they have multiple levers that they can pull. Secondly, that CMS is both empowered by and constrained by Congress. And so there needs to be a true partnership and common visioning across the legislative and executive branches about how to solve this problem in the long term. And it's not a partisan problem. It really is not. Your PCP not showing up, they don't really care whether you're voting red or blue. So I say all that as context for my recommendations, which is assuming this tightly coordinated statutory and administrative partnership, right? So if I were the whisperer, I would say, let's split the fee schedule. Let's put the procedures in one place and the cognitive services in another place, because the current budget neutrality rules are not helpful, and they create a food fight every year that distracts us from what is necessary to be done. The fallacy is that for a system, the assumption that for a system to be more efficient, you have to save money in every bucket. That's actually not a system. That's just a series of buckets. A system is more efficient when you have right-sized the spending across the different buckets. Excuse the 24-year-old in the background. And so that's Act 1. I think Act 2 is, generating the kind of thoughtful data collection on what it actually costs a PCP to deliver the kind of care we want, and then paying accordingly. CMS has never had the luxury of the data collection resources that it needs to do that appropriately. And so, lots of others step in to fill the void on procedures, but primary care specialties don't have that luxury to explain to you what is the cognitive load of dealing with my patient's very complex problems, because it might well be akin to neurosurgery, but I can't prove that to you in the current data collection processes that you have, right? And so there's that aspect too. I would also say we believe that CMS many of us believe that CMS has the statutory authority now to take bold action. For example, not as a pilot, but as a feature of the permanent Medicare shared savings program to offer a different way to pay primary care. A hybrid payment, one that is priced significantly above where we are today, and one that is that has cash flow that flows directly to the primary care practice so that they are in control of it. And they can make the best decisions about how to flex that across their different patients' different needs, and give them revenue stability. But we believe that, with a little bit of a tweak and some legal reassurance, that CMS can also do this in traditional Medicare. And then the next step after that would be to demand that MA plans reflect that in their compensation structures for their primary care contracts. And then similarly, even on the traditional Medicare side, in ACOs, we have never held ACOs truly accountable for how the Medicare incentives trickle down to their frontline clinicians. And I think we are spending enough money as taxpayers that we have a right to demand that, and to know that it is being spent how we think it should be spent. And if the business proposition is right, they will do that too. And then I would also say, as Shani mentioned, things we don't value. Well, to value them, we have to be measuring them. And we are not consistently measuring the outcomes that matter. And that's partly a selection problem, right? CMS, I think, has a historical tendency to react to what the field is doing. Whereas I think CMS has the opportunity to look ahead and say, where do we think this market is going to be in 5 years? We need to start signaling that through our quality measure selections now. Right? And similarly, the field is trying to anticipate CMS. Sorry, I'll stop.
Yeah, no, lots to think about. I invite any of my panelists to jump in and react to my or put your own thoughts on the table.
I wanted to just say it's fascinating listening to Pi and getting that bird's eye view of what can be done and why aren't we doing it. I also think we'd be remiss to I'm thinking about team-based care, and so I mean I'm very being out in the field, I'm like, to me, I'm like, stabilize the people we have now, so how can we stabilize and stop the bleed, right? It's like, be a doctor, stop the acute problem. So it's not just people aren't going into it, people are leaving, they're aging out. There's a lot of ability for doctors to quit too. You can reduce your panel size. I've seen a lot of women go half-time. A lot of women are taking remote jobs where they can do, every day they're like, oh, I'm looking for something in industry, or I'm looking for something new. You see this all over the Facebook boards, physician moms groups, and physician side gigs. So right now it's stop the bleed, keep people where they are, keep them going. And that might require immediate bonus structures and other things to be like, we value you, keep your door open. What can we do to help you? And that is going to signal a long way that the tide is changing and people care. And then the other real issue here is, I think we would be remiss in this panel not to mention nurse practitioners and others. Caregivers were mentioned. So I mean, we need to be part of the team. Nurse practitioners are part of the team in many rural areas. It's a nurse practitioner. For my kids, for urgent care, I cannot see a physician. I take them to a nurse practitioner. And so we need to not have so much hubris that it's only going to be a physician, but we can all work together in a team model. How do you enable that team model so that you can actually have keep your panel going? And so I think a lot of that can be built structurally and rewarded structurally. And that's why it's great to hear from what I would say is we've got to have that something done drastically to let people on the front line know help is on the way and we value you. That is the first step. Then we can start working on the bells and whistles to bring more people into the field. A lot of people are like, oh, just get some more residencies. I was like, more residencies with what you currently have at the end of that train is not going to help you. So we really need to signal to our primary care community that they are valued, and that signal will then automatically encourage and invite others to join them.
Vinny, thank you so much, because I think a lot of folks are like, how do we get more into the pipeline? And then it's like, well, that's a decade. We're going to see the results of that. As you said earlier, stop the bleed. Toby Ashani.
I'll defer to you, and I can jump in as well.
Sure. Well, as everyone is talking, I'm also always cognizant of the consumer's perspective and how daunting our healthcare system is for consumers, and primary care providers are often their first touch point. But I think it's easy to lose sight, even being in healthcare and healthcare policy, at just how daunting it is to enter our healthcare system and to navigate it, especially for providers, or I'm sorry, for patients who might be facing multiple conditions, acute needs. They might have cultural, linguistic, other challenges, all these things that primary care providers are on the front lines of needing to help them navigate. And so when we're thinking about healthcare leaders, I just always think it's really important to make sure they are finding ways to regularly hear from their members and patients, consumer advisory boards or other ways to do this. It's just so critical to stay grounded in the experience and needs of those who are ultimately using the systems, and to make sure that the policies and practices that are being put in place are ultimately going to help those patients achieve better health outcomes. And I think that the healthcare leaders can really set the tone for the organization in terms of what's important and how to remain focused on the end goals. As we're talking about today, too often we don't pay professionals to spend the time needed to help patients understand and navigate the system. And so often that doesn't happen to the extent that it needs to. And I think it is often best addressed through a primary care team-based approach. So making sure that to the extent that a healthcare system is able to make adjustments to rates, paid, salaries, et cetera, to make sure they're taking into account more than just a straight transactional number of visits in a meeting, but also the full context of what it takes to do a really good job in primary care: preparation, coordination, collaboration with other providers. I hope that that's something that healthcare leaders routinely make time to do, or make time to start doing as soon as possible.
Toby, thank you for that. Because I think actually appealing to decision makers when they think about what kind of primary care they and their family gets, and they may reflect that it's not exactly, it might meet their needs because they're members of Congress, but they certainly have family and friends where it's not meeting their needs. And to bring the patient voice forward is really important. We appreciate our partnership with AARP. Mai mentioned this work to try to introduce a different way to pay through Medicare's largest ACO program. We're hopeful that CMS takes that idea up. They are exploring it. It's an idea that in partnership with NACOS and 30 other organizations we brought to them. But it's just one idea. We need multiple ideas, and we need this not to be something that takes 2, 4, 10 years. It's like, we've got a crisis now. So how do we respond now? I also want to underscore, comments about team-based care. And we have a question in the chat about, there's legislation in states that would allow PAs and NPs to practice independently. Could that have an effect on primary care access? So that's just a question that's come in from our participants. Anyone want to take a shot at that?
I'm happy to go first and say that there are differences in training for nurse practitioners and physicians that are important to acknowledge. However, given how access needs to be pivotal, and so I would say that I would defer to states on what their workforce supply is. It looks very different in certain rural parts of the country than urban parts of the country because of this geographic maldistribution of physicians. States should be free to make those decisions for their constituents. The other thing to think about also is international medical graduates, which we haven't talked about. In a lot of rural areas, it's through the Conrad 30 and the international medical graduates through visas that are providing those primary care, filling those internal medicine residencies. There's actually pathways for international medical graduates to practice, direct practice, if they have met certain credentials. Those can be opened up. If those are opened up, those people can get to practice faster. And then those residency spots are also released. So there's ways to actually decrease the, get some more workforce in right away. And I think some states, including Illinois, are exploring those right now.
I would agree with all that, and I would say it can't hurt and it doesn't solve the problem, because nurse practitioners also get tired, and international medical grads also have the choice of other specialties and procedural specialties. So it can't hurt, but we will not have solved the fundamental issue that is burning out the entire primary care workforce.
Yeah, I understand that NPs and PAs are also not selecting primary care to the degree they once did. So, I think the workforce is voting with their feet, and the conditions under which they're being asked to work are not a satisfier. And if, as your study shows, Shani, if you extend yourself to meet the needs of the patient by providing more time, you get penalized. And many don't feel that they can do that. And, there was a New York Times Magazine article about moral injury. You're not able to provide the kind of care you want, and patients aren't getting the kind of care they need. So this is a no-win situation. It doesn't work for either side of the desk, and it is not going to be incrementalism that's going to change that. We haven't really had a chance, and I'm looking for a couple more questions. One that's come in through our panel or our participants is, well, what about health systems? Many primary care clinicians are employed by health systems. They have the ability to change how they pay. Why aren't they, and what might they do?
Yeah, I can take this one. So, I think it goes back to what Mai was alluding to earlier, that there's so many levels at which we need to have concurrent change in order to see real effects. And it may be the case that CMS incentivizes ACOs to reduce spending and improve or maintain quality outcomes for a population of patients, but that doesn't require that ACO leaders are then translating those that savings or that money in specific ways that would support primary care and allow primary care clinicians to do the activities that would actually improve ACO performance, right? So the PCPs in an ACO contract are meant to coordinate care with specialists. Now, if there's no structure in place to actually do that, no situation in which specialists are actually, there's a communication channel or relationships that are built to make that happen, you're not going to get that effect. And there's also no requirement, as Mai was indicating, that PCPs are paid any differently. And that's something we still see largely fee-for-service payment across health systems as well. And so I think, I guess one solution, I hesitate to offer more incremental changes, but ACOs could incorporate other performance measures that are more aligned with those ideas. Also, going to Mai's previous point, measuring other things or holding as performance metrics aspects like continuity of care or other aspects of relational care that we value, and using health systems and the growth in health systems to promote some of these aspects of care that are really important in primary care.
And I would say, Anne, that a lot of it has to do with the margins. So something like 50% of US hospitals had neutral or negative operating margin last year. Now, that means also that the other half didn't, and some of those are doing very, very well. But what adds up to that overall margin are the margins on individual procedures and admissions, et cetera. And frankly, the margins are just much more attractive for certain services than for primary care. And that's something that can only be fixed through a combination of CMS action and regulatory action to create a healthier competitive market out there. Because right now, the must-have health systems have a lot of market power to negotiate ever higher prices for higher margin procedures and admissions. And that just leaves less payment oxygen in the room for everything else, including primary care. And private payers by themselves cannot right that ship. So it has to be a real concerted push. And that makes a lot of people very anxious and nervous. and kind of the reflex is to say, well, but you know, hospitals are major employers and they play such important roles. Well, they're not. It's not about pushing them over the economic edge. It's about redirecting their priorities.
Thank you. This was a terrific panel. I just want to follow on your comment for a moment too, because downstream from you know, this incenting of more acute and specialty care and higher margin care, we're just creating a healthcare system that is less and less affordable. And so the patient, you know, forget it. They may have coverage, but they actually can't avail themselves of it because it's way too costly. And, you know, they may be in a benefit design where they have such a high deductible that they're just not going to get that care until they, you know, absolutely need it. And then they're in the ED or they need to go to the hospital. So
right. Medical debt is now the leading cause of personal bankruptcies.
Yeah.
No one's going into medical debt over primary care payments.
No, absolutely not. Absolutely not. Well, thank you so much for an incredible conversation. And I think everyone enjoyed this hour with all of you. This webinar will be posted within the next 48 hours. We encourage you to send a link out to all of your colleagues and friends who weren't able to tune in today. We encourage you to come to our conference on November 16th. Please join me in thanking this incredible panel, and we'll see you next month for the release of PCC's 2023 evidence report. Have a great afternoon.